So welcome to another installment of our series, Power of Pivoting, Managing Through Crisis, the HSS experience with the COVID crisis. I am C. Ronald McKenzie. I'm an internist and rheumatologist at Special Surgery, and I'm the moderator for this series. So we have two of the major leaders of our hospital here today to discuss this experience. I'd like to welcome Dave Mayman, who's a national expert in computer-assisted hip and knee replacement, chief of the surgical arthritis service at HSS, and associate professor of orthopedic surgery at Weill Cornell. He also temporarily, he tells me, is holding the position of chief medical officer of New York Presbyterian Hospital at HSS, and we're going to learn what the nature and responsibilities of that position are. And then Jennifer O'Neill, who's our Chief Nursing Officer and Senior Vice President of Patient Care Services. Now, interestingly, she came to us a year ago from St. Barnabas Medical Center, which is, I think, what, a 600-bed hospital in New Jersey. I think a very fortuitous arrival for somebody with her background, given what we have had to become in the last 8 weeks. So we're going to talk today about the transitioning of our hospital to the care of COVID patients from a place that basically performed orthopedic surgery until 2 months ago. So I think a good place for us to start, I think, would be to have each of you describe your respective roles during this recent period.
So, as you mentioned, I'm an orthopedic surgeon, do hip and knee replacement, and all of a sudden we were not doing hip and knee replacements. But the hospital recognized very quickly that we needed to help the community through this endeavor. And we had to very quickly decide what that was going to look like, what this hospital was going to look like. And it's been an evolutionary procedure, but early on, the leadership at the hospital said, okay, we need to put a couple of people in place that are going to be able to look at this, make decisions quickly, and then act on those decisions in order to take this hospital and allow us to serve the community in the best way we can. So I think they wanted a physician and they wanted a nurse to be able to take those roles and say, okay, let's go, and not have a lot of bureaucracy. So I got the title of Chief Medical Officer. Jen was already Chief Nursing Officer here, so that made sense. So the two of us were teamed up to take this hospital and move as quickly and efficiently and safely as possible to a hospital that could help in this pandemic.
And my role is Chief Nursing Officer and also Chief Operating Officer. So I was, majority of what I needed to do was make sure we had a good collaboration with NYP. So we had a point person over at New York Presbyterian so that we can safely transfer patients over. And then with Dr. Mayman, Dr. Ligori's team, as well as Dr. Russell, making certain that we screened patients to safely transfer them over the bridge and make sure that we had the tools and equipment to manage these patients. So like Dave said, we needed to act quickly. So as soon as the decision was made to reduce essential surgeries, we needed to start thinking of what tools that we needed that we could safely care for these patients and transform many units. So we installed telemetry on our 8th floor, so we have wireless telemetry now with continuous pulse ox. That's an additional safety tool that the staff can use. And then obviously we transformed our 9th floor ORs into ICUs, and it was a true collaboration between materials management, supply chain, GE, everyone just moving so rapidly. I think I make it sound like it was easy, but we were able to get a telemetry unit up in a week, an ICU up in 2 days. I mean, it's truly collaborative and transformational.
And so who were you interacting with at New York Hospital?
Initially was their ED leadership team, because the first stage was to help decant their emergency department. So Dr. Bodner was a key individual in that process. Dr. Mayman's really taken over the ED and the ORs with Dr. Ritchie, And then Kate Halpern, their chief operating officer, in contact with probably daily in the beginning. And Dr. Gupta, who is the medical chair over there, was in contact with Dr. Russell. Then we expanded to Lower Manhattan, and taking patients from Lower Manhattan, and then expanded to Queens because Queens had a need. So there were key physician leaders in each of those roles to ensure good communication and safe transfers.
So, something the audience might be interested in, you mentioned the telemetry unit. So that required the addition of equipment here, for instance, that we wouldn't typically have, right? And so how was that organized? Where did that equipment come from? I mean, it obviously happened very rapidly, so it was an extremely efficient mechanism you developed.
So I think with our partnership with GE and Lou's relationship with GE, we were able to quickly obtain the equipment and then install with materials and biomed and engineering. And then we have new equipment, so we need to train. So it's just-in-time training for the nursing staff, which it can be overwhelming. Yesterday, on the 8th floor, we were able to move a step-down patient down to 8 because we've now also installed hardwired monitors, step-down monitors on 8, so they can care for COVID-positive step-down patients to maintain patients cohorted. And so their first patient went last night. So as we're seeing patients, the staff is committed to overtime to be trained on weekends, and everyone's just been fluid. So I have a PACU nurse that went from the 4th floor PACU up to the 9th floor ICU to the 9th floor PACU. Now she's on the 8th floor, precepting 8th floor nurses so that they're comfortable in caring for these patients. So it's just been an amazing journey to watch, to see how the frontline staff have just been, roll up my sleeves, we need to get this done to make sure that we care for the community.
And Dave, maybe speaking of this fluidity of roles, that's obviously also been assumed by the orthopedic and medical people, with residents serving in frontline functions and even attendings. Can you tell us a little bit about that?
Yeah, I think everybody's been fluid from anesthesia on down, right? So we have a few people who are trained critical care anesthesiologists who typically do orthopedic anesthesia but do care for our critical care patients here. They became full-time ICU physicians taking care of COVID-positive patients. Their colleagues who are anesthesiologists who don't typically take care of critical care patients were up in the ICUs helping them. We had our trainees, both our residents and our fellows, on the floors, in the ICUs, assisting, learning, being fluid. We had orthopedic attendings that were all of a sudden on the floors, in the ICUs, acting as scribes more than anything else, just everybody trying to help. And we can't forget our medical physicians who, we have our hospitalists, we have our internists who typically here are doing medical clearances for surgery, most of the time on relatively healthy patients. We do have our complex patients as well. All of a sudden they were running inpatient floors. They've all been trained to run inpatient floors, but a lot of them haven't done it in a long time. And then we had all of our typically outpatient physicians, our rheumatologists, our physiatrists, our metabolic bone people, all our neurologists, all of our typical outpatient medical physicians also chipping in, right? Some of them coming into the hospital, some of them calling post-operative patients or post-discharge patients. Everybody, really, I'm really proud. Everybody just, as Jen said, rolled up their sleeves and said, all right, there's a fight. We've got to get in this fight. How can we help?
And I would also add, like, surgical techs, unit assistants, right, all redeployed out of the OR to function as patient care assistants. So they got rapidly trained, as well as housekeeping, which is also a vital part of keeping this place safe.
Yeah, I know it was really quite remarkable. People assuming roles that they're haven't performed often in many years and doing it extraordinarily well.
So at the same time, we didn't have to ask anybody to do anything that they couldn't do. And I think that was an important part of what we did here. If you listen to stories from other hospitals, there were people that were put in positions that they were really uncomfortable with. You hear stories of a plastic surgeon who was all of a sudden in an ICU without any backing, right? Because some hospitals were just so overwhelmed. So they got a day of training and all of a sudden they were supposed to be an ICU physician. We didn't do that with our physicians. We didn't do that with our nursing staff. Yes, people had to assume roles that they were uncomfortable with because they hadn't done it in a long time, but I don't think we took anybody out of what they were actually trained to do.
Or left anybody unsupported.
Or left anybody unsupported.
I think that was the key too, is we really had to move to a 24/7 hospital operations, and so we redeployed a lot of leadership and nurse practitioners, PAs, and educators that were around the clock available so that the staff felt supported.
And Jen, I think you can probably comment on this. When all of a sudden we had an ICU and you had to have nurses in your ICU, and if you talk about nursing ratios, you had, I think, 2 nurses for every 1 patient initially as people were getting trained, just to make sure people were appropriately supported?
Yes. And again, redeployed individuals and charge nurses to assure that it was a safe environment.
What about empowering and engaging and supporting your staff? How did you approach those challenges?
Well, I'm a firm believer in that the decisions need to be at the front line. I think we had to move so fast, and there were so many decisions that needed to be made. I had full confidence in this team that they could do it, from the frontline staff to the leadership team. So I trust the decision making. If there are things that they needed to run by me, they could, but it was like, if you need something, you're fully supported, I have your back, make the decision and move forward. Sometimes you make the right decision, sometimes you make the wrong, but it's okay to reflect back and say, oh, let's step back, let's take a minute and see, was this the right decision? You know, we'll probably debrief and reflect and say, oh, I should have put telemetry on this unit, not this unit. But you know, when you have to move quickly, you have to be able to make decisions.
Yeah, and I think nobody was stubborn, which was nice, right? No, because we would meet for 10 minutes with 5 people or whoever it was. We'd make a decision. We'd move forward with that decision very quickly. And you're right. Sometimes 3 days later, we said. 20 minutes later, we said that was the wrong decision, and we pivoted. And everybody just pivoted and moved on. We did that a number of times with the ICU. We talked about where the ICU was going to be, which beds it was going to be. Was it going to be in the PACU on the 4th floor? Was it going to be up on the 9th floor? Was it going to be the recovery room on the 9th floor? We changed that multiple times. And every time we changed, I've got Greg Ligori's voice in my head. He's like, okay, right? Every time it was just, okay, and we moved on.
So do you each have an example of what you think was the most enduring experience or profound experience you've had over the last 6 weeks?
I think for me, it's watching the staff and how caring and compassionate they are. They don't want anyone to die alone, so they assure that there's a provider in the room holding a hand, talking to them. They FaceTime with the families to assure if they want to see their last breath that they're available. It's that their heart is what's probably the most profound. I had 2 nurses the other day tell me this is their first experience of FaceTiming with family. It's quite emotional. And one nurse, you know, obviously she was in full PPE, there was somewhat of a language barrier, and she just felt that she couldn't reduce the level of anxiety of the family to let him know he was doing better because of the communication barrier, and that all of that PPE that she was wearing probably really stressed out the family. It's those moments, I think, that just continue to make me proud, and they're just so touching.
Yeah, I think you're right. It's seeing the heart and the soul of the people here at HSS. And, you know, we always talk about how proud we are that we're #1 in orthopedics and how we always strive to be the best. And the fact that I think we saw that we can be the best even when we move outside of our comfort zone just shows the quality of the people here.
So it must have been challenging, on the other hand, to manage all your other pre-existing responsibilities, or did they just go out the window? I think Dave's went out the window.
Yes. So obviously my surgical stuff went out the window. But the other thing that's happened here that I think will be transformational for us moving forward is what we've done with telehealth. And although, you know, everybody was kind of playing with it a little bit before, and we had talked a lot about it before, we had never really engaged with it. And I felt like our patients hadn't really engaged with it before. And over the last 6 weeks, Everybody knows how to use Zoom. Everybody knows how to use Skype. My parents can use this stuff now. And I still see 5 or 6 patients a day using telehealth, and most of those are post-op checks. A lot of them are routine follow-up visits. More and more, I'm starting to see some new patients now. That becomes the normal part of my day. I look forward to that. It's between 1 and 3 every afternoon, and I'll get a phone call. My phone will ring. It's Brian Kelly or it's Jen, and I won't answer because I'm on Zoom with a patient. So that's how I've tried to keep a little bit of my day normal.
This is like a typical day for me. So for nursing, it's just a different patient population we're serving. So I don't think too much has shifted, other than making sure that the emotional needs of the staff. I mean, obviously this is a very trying time. There's probably going to be some individuals that retire or decide not to come back to the field, and so just assuring that the anxiety level is at an appropriate level for the time being.
So I thought I would just conclude this with one final question, although I think Dave just anticipated it with his comment about telehealth. And how do you think this experience is going to change the Hospital for Special Surgery going forward?
Well, I think we'll be stronger. I can definitely see in the nursing staff the level of confidence has increased. Some of the staff on 8, or because we're making them a COVID positive step down for the future, want to know when COVID goes away, can they remain step down? There's definitely been an increase or advancement of their scope of practice. So there's a lot more confidence. I think some of the staff said, look, we don't need to send any patients to NYP. Look, we can manage them here. And I think that is, again, what the culture of HSS is, which is to continue to excel and be number one in whatever we do.
Well, Jan and Dave, listen, thank you very much for doing this and your leadership during this last trying period. And we're going to come out stronger. I think we all know that.
Thank you.
Thank you.